recording.
Great.
Dr. Hildebrandt.
Here.
Rob Chapinelli. Not here yet. David Kader. I thought I saw him.
He was on licensing.
I thought I just saw him on this.
Yeah, he's
Probably
there.
grabbing lunch.
No, he's there. He's muted.
He is. He is on.
Yeah. Evan Eiler.
Here.
Gail Falk.
Present.
Rachel Gades. I thought I saw her.
I do see
Yeah,
her.
there she is. Yep. Peter Ireland.
Here.
Suzanne Jones. I don't think I saw her. Pat King.
He's on.
You're
Show
muted,
here.
Pat.
Stephanie Lorenz. I'm pretty sure I saw her as well.
I'm here.
Yep. Okay, thank you. Ian Odigi.
Present.
Don Philibert.
Present.
Judy Scott.
I'm here.
Margaret Tando.
I'm here.
I see you there. Yep. Tortolani absent today. Scott Tucker.
Here.
Megan Campbell.
Here.
Kurt Kuehl.
Present.
Bill Reynolds.
Here.
Justin Sheng. I see him there. Scott,
Out.
is Scott Frenier here?
I'm here.
Tracy Hayes, are you here? No. David Hurley, he is here. Paula Nenninger's absent. Marcy Quinlan is here. And we have a number of guests. Rick, do you want to?
Yep.
Go
Who
through
do we have for guests?
I don't see them on yet. We're gonna. They'll be on later, so we can acknowledge them later, I guess.
Ron, I think you might have missed me too, Greenberg.
Oh, thank you very much.
We've got two people who have called in. Who are those folks?
I'm one of the call-ins, I think, because I could not get sound on my computer, so it's on the phone.
No worries. That's Rachel. And who's the other one? 96?
David Kader. I'll
Okay.
be joining by computer, but computer problems right now.
Okay. And there was a Heather, I didn't catch her last name, that I think jumped off. That I think was a
Schultes.
guest.
It was
Yeah.
Schultes.
But I think she's jumped off.
Yes,
maybe
she is associated. She works with the Naturopath Association, and I think she'll probably jump back on at the time when that comes up.
Okay, great. Is there any public comment? Hearing none, we'll move on to the approval of the minutes from the September 4th board meeting, and I'll entertain a motion for approval of those minutes.
So move, Kader.
Second, King.
Great. Any discussion? All those in favor, please say aye.
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 Any opposed? Great. Next up is board issues, which I don't think I have any board issues that I'm aware of anyway. Next up would be our administrative update. David.
Yes, first, just so I don't forget, we're gonna have a busy agenda today with two groups of visitors. The first one about the naturopath issue, and the second one a visit with the medical director and some other personnel associated with the BIPIP program. And so we may have to, if we're not done with the naturopath issue, we may have to leave that and continue discussing it. I think we'll be done with the visit by the time the BIPIP program comes up. We may have to revisit that. So try and keep on track here today. The first update item is that as of August 30th, we had 5,846 MD licensees. I told you last time it was 5,815. There were 31 hiding. It was not a Tracy error, to be clear. It was a system error, and we actually had the contractor fixing it. We had 31 people who had a quirk and something else going on. They were getting a verification done, and they weren't included in the count. Of those, oh Lord, Tracy gave me the most recently updated numbers this morning, and I didn't get them into my notes. We have, at this point, out of the 5,846, 1,592 have submitted. So that's pretty good, at about 30% or so. Of those, 1,208 are people who got their license through the regular pathway, 384 who had gotten their license through the IMLC pathway. Tracy has processed 1,165 already, 781 people who got their license through the regular process, and all 384 of our IMLCC licensees who submitted have been processed. So she is making great progress on that, and we'll be coming up the middle of this month. We'll be at the 6-week mark, approximately halfway through the period, and we'll be starting to send out our reminder messages at that point, trying to encourage our MD licensees to get their renewals in. Second item, I met on Monday with a group convened by Senator Wendy Harrison of Windham County and Representative Leslie Goldman, who's also represents one of the districts in Windham County. And there was also a number of advocates interested in the foreign trained physician issue. And they are very interested in having a Vermont version of one of these alternative pathways into law. Several of the people on the call are advocates for the refugee community, and someone who's active with the NAACP, and also 2 individuals who are associated with World Education Services, which is a nonprofit that promotes recognition of overseas education and support of immigrants and refugees and having their education and qualifications recognized. And again, they're very anxious to have a bill this session, and this is sure to be a focus for the board during the session. The advocates in the group spoke at length about a report from an advisory group convened by the state of Massachusetts, and they expressed their belief that Massachusetts and Virginia will soon be passing laws based on this Massachusetts report and the recommendations in that report. I've gotten a copy of it, and I was a little bit disappointed because the report does not meaningfully address 2 significant concerns that were prominent among the states at the June meeting, and that Rick and I attended, and I think those were big concerns in our eyes, as well as the larger group. And those are the capacity of a medical board to evaluate an overseas residency program, and also the challenges and need for resourcing for the task of training physicians who would be asked to train and evaluate participants in an alternative pathway program. And so we will for sure be discussing this more. I'll send out a copy of the report and share it with you all in advance of our discussions, and more to come on that. On a related note, in a call last week with all the New England board chairs and executive directors, that Rick and I were both on that call. The FSMB president, Hank Chowdhury, mentioned that the report from the advisory group that includes FSMB, ACGME, ECFMG, and a number of other stakeholders should be issued in the very near future. And I think that could be possibly as early as this week, or perhaps a little bit longer. There are a lot of people who need to sign off, I would expect, on that final draft. I attended a meeting of the FPMB, the Federation of Podiatric Medical Boards, yesterday, and Ian was on the call with me as well. Thank you, Ian, for joining in and spending your lunch hour online, hearing about a proposal to initiate a podiatry compact. And the podiatrists have opted to model their compact very closely on the IMLCC. So it's something that is easier for us, I think, to wrap our minds around, because it's familiar to us. And it was mentioned during the call that the IMLCC has made an offer to the group that's looking at this, that should the podiatry I don't want to use the wrong term. It's not just the FPMB, but the podiatric community succeed in having a compact brought to life, that the IMLCC would be willing to be the administrator for it and to use their systems to support that. And so we may be seeing that as early as this session, I believe, and we'll keep our eyes on that. And my initial impression is it's something that we could support and would welcome. We need more podiatrists, and we'll see what comes to that. Every month I've been telling you, we're still working a lot on the IT system. We're continuing to work on negotiating the contract and preparing for the next step, which is final approval of the contract and the project by the state's CIO, Chief Information Officer, who is the Secretary of the Agency of Digital Services. So that continues to be quite a commitment for myself and Ron and Tracy and others, other staff members. And that's all I have today for the admin update.
Great. Thank you, David. David, question about the desire of some to have legislation around the foreign trained physicians. Is there a working group on this, or is there a bill sponsor, or is this just sort of scuttlebutt?
No, well, Senator Wendy Harrison and Representative Leslie Goldman were on the call, and they both seem to be very supportive and interested in introducing legislation. To get a bill introduced, you need to get a representative or a senator who's willing to do that. I think that we'll probably see identical bills introduced in both. And again, it's the concept. It's I have to say it's a little bit better than what we saw last year in Tennessee that ended up being withdrawn and replaced by a new law. It's basically putting into law that the medical board would create rules for overseeing a process to allow foreign trained physicians who've been licensed in other nations to work in certain limited circumstances, recognized work environments, and that could be limited to hospitals. Some states have limited it to teaching hospitals. FQHCs have also been discussed as having the capacity potentially to do this, and there is just on that note, there is a effort to get a new residency program in Vermont that's based in a collaborative group of FQHCs. Yeah, we'll have to deal with that and
Would there
see
be an
that,
opportunity to potentially inject some intelligence into this before it gets too far down the path? As it seems like there's a knowledge gap.
they've asked me to participate with this group, and they were very welcoming, and there's one both people who are associated with World Education Services, where they're very knowledgeable about medical credentialing and licensing, and they it's a nonprofit. They're not just trying to sell their services. They do get a fee for the work they do assessing, but they are, as an organization, they're very committed to supporting immigrants and refugees. I think that it's going to be a challenge to convince the legislature that having the resources to train physicians to evaluate and train people outside of a residency program is going to be a very difficult task. And again, I anticipate that to be probably the number one issue for us in the coming session.
Yeah, there's a path to do this well. We just need to have the structures in place, right? So the WFME needs to actually start accrediting programs, and until or unless that happens, it's dead in the water, because we can't even assess the residency programs, and they have committed that they want to start doing that. So I mean, even if we were to make rules saying, hey, if we have an approved residency program by the WFME and an approved training and onboarding program by the employer who's going to be selecting this individual, the end's going to be zero, because none of those things are in existence. So I mean, we can certainly make some rules. It's just if they don't understand the requirements for an onboarding a foreign trained physician, then I think they'll probably be more frustrated than if we just try and sort of educate them to, hey, here's the things that we need to do.
Oh, I brought this to their attention, and they were very, as I said, they were welcoming and they were gracious and listening to me, but I can say with certainty that they are all very committed to trying to go down the route that a number of other states are either have done or are looking to do, which is to not be concerned with the accreditation of the foreign training program, and instead to use as a proxy for accrediting the programs, just simply evaluate the knowledge and readiness of the individual to practice. And again, I think you and I, you know, and a lot of the participants at the June meeting were concerned about, you know, I think in our system as much as we're really in need of more primary care providers, I think that would really take up a lot of the bandwidth of our primary care providers to get involved with providing that kind of oversight and evaluation for any significant number of people who are going to get licensed in this way.
Well,
Would that be oversight and evaluation through a residency program?
No, this is the whole idea is alternative pathways, so that rather than using the established model, which is to license people based on their completion of recognized training, to instead just rely on the fact that they A, were licensed, and B, they've had this evaluation and assessment. And to be fair, they also recognize that they need to require, and states have, there's been, you know, the recipe hasn't been quite identical in every state. Some states require the same ECFMG results as it takes to get into a residency program, which is completing step 1 and 2. And then when somebody comes and they've graduated from an international medical school and they want to do a residency in the US, they have to complete 1 and 2 in order to get their ECFMG certificate. And then they have to pass step 3 while they're in their residency program. And so, you know, there's some states who are going with, well, we'll allow people to participate in this supervised period of evaluation and training in the state after having done that, and then allow them to complete step 3 and make that a requirement before they get an unrestricted license. Again, I think we need to see what is in the report that comes out from the group and see how strong the recommendations are there, and see how the tide turns in the many states that are considering this. And I think if there's a good number of the states and hopefully a majority of the states decide that it's a better course to wait for the establishment of a framework to evaluate overseas residency training programs, then we would be successful in saying we need to wait for that. If a number of states continue moving forward with this alternative, which focuses not on the training program, but on the individual, and puts the onus on people on the ground within the state to determine if the individual is ready or not, then if a lot of states are doing that, I think that the legislature is not going to be interested in waiting, but we'll see.
Evan.
Yeah, psychiatry is a field with, I think, the highest percentage of international medical graduates, although these are people who have attended medical school in other parts of the world and then done residencies here and stayed and practiced. And so it's very well accepted. And the issues that come up for people follow that path is the need for onboarding regarding cultural issues. You know, we talk a lot about cultural knowledge when working with someone whose cultural background is different than one's own, and it works in both directions. Without some kind of onboarding and education in that regard, I'm really concerned about vulnerable populations. In approximately half the world, same-gender sexual behavior is unlawful, and in many places results in imprisonment or worse. Here it's fine. And it's expected that one see members of the LGBT communities in one psychiatric practice in an equitable, fair, and knowledgeable manner. I've had people ask me questions about women's sexuality, where clearly the frame of reference was extremely different. And none of this is judgy. It's to say it's a big world. And if you move to another place, there are some things to learn. And that's very evident in psychiatry. It was also evident in family medicine. But the thing is that the way it works now is that there's a residency program. You know, the fact that someone can pass step 3 doesn't address any of those concerns at all. You know, there's a need for some work under supervision and so forth. I think it may be quite different in, say, a surgical field. But, you know, for ones that have to do with people's intimate lives, psychiatry, primary care, OB-GYN, et cetera, I think there's a real there's a gulf that needs to be bridged. And I don't see anything in steps 1, 2, and 3 that does that. You know, residents who follow the pathway that we have now say that it's really helpful, you know, that you get to talk with someone about clinical concerns in real time and, you know, learn how we do it here. That, you know, if someone from the US goes elsewhere, there's a similar need for education. So I worry the stated reason is to put more primary care physicians in rural areas, which is already an area of vulnerability. I would support, but only with some kind of direct education and supervised practice, rather than relying on written tests for something that isn't well represented in written tests.
Well, and again, Dr. Eiler, first of all, you are on the short list for the people who I will call for testimony to help us present the board's position. And second of all, I think, you know, the well-intended people who are looking at this from the perspective of the individuals who want to be able to practice here are, you know, they're focused from their perspective, and it's going to be our job to illustrate some of the other concerns that need to be taken into consideration when the legislature decides, is it going to be enough to create, which, you know, I refer to as a pseudo residency process, of which, you know, residency is training and evaluation, and that's what they are the states are coming up with, is a system that's not a residency program, but that provides for some measure of training and evaluation. And
right, but it's also, it's beyond that too, though, David. So it's not like you could be the world's best surgeon and do a surgical procedure, but if you don't understand the American medical system and the systems in play. So there's 3 elements that we talked about a lot about at that conference. It's your medical education and training. We've got that figured out more or less. Then your residency training and education, we have no way to assess foreign residency programs. And frankly, sometimes literally people send checks to a PO box and get like diplomas. I mean, that is a thing that exists in this globe. And then it's cultural onboarding. And you need to do all 3. You need to assess someone's medical training, their residency training, and their cultural onboarding needs to be addressed. And we don't have solutions for the last 2 of those. Anyway, I don't want to cut people off, but we do have a bunch on our agenda, so I'm going to go to Pat next. Oh wait,
Thank
sorry.
you.
No, Ian was next. I'm sorry, Pat. Ian was next.
Go ahead.
So, David, I just had a quick question with regards to the podiatry compact license. I know they said they needed 4 states to initiate the process. Do you know if Vermont is going to be one of the states, and how would that proceed?
Well, again, they would be presenting it, and they'll be distributing, they'll refine, they had a draft. They'll refine that draft, because once it is passed by any of the states, it's, that needs to be what's passed by every state. And it's difficult for the board to get it introduced. I think that might be something for the Podiatric Association. It would be easier for you all, because there's a very lengthy and involved process in the state for us as a board to recommend go through the chain of command to the governor's office to get the okay to have it introduced. But if the Podiatric Medical Association got it introduced and we were asked to testify, then the board could be supportive.
Thanks, Dave.
Now, Pat, sorry.
Yeah, thank you. My comments about the foreign trained graduates are really just about process for us. I think David's right. First of all, that report or the recommendations from the Federation, ACGME, and Intel are going to be out, very soon, very soon. So that will be a helpful guide. The other thing I just wanted to mention is the importance, as Rick mentioned, and as David knows, is being involved with all of this in terms of the legislature early on, and to be very respectful of all sides. I listened into the Tennessee board meeting for September regarding their statute changes, and it was really kind of a mess. The first bill that put through took effect July 1st. They had no rules in place, and people really didn't end up liking that. So they actually had a second bill that takes effect at the end of January. So they've got this, or January 1st, something like that. But they've got this 6 month of being nowhere with rules no one liked and didn't intend. And it was not a good process. It was confusing. It seemed to really alienate the two sides, maybe to some degree, and it wasn't good for the public really at all. So I think being involved is really important early. I'm not sure Tennessee was, and I'm not sure why they weren't, but and being involved early, being respectful, and if there is something that comes out, making it the best possible for the public and the individuals involved, because you just don't want to have happen what happened there.
Yeah, they were excluded from the process there, and there are a lot of a lot of different forces at work here. And one of the things that came out at the meeting in June, were you at the meeting, Pat, in DC?
I listened into it.
Yeah, that one of the big funders of the efforts to push for this is money from private capital, private equity. And there's a guy named Joseph Lonsdale who's heavily invested in healthcare companies. And it's, there's some concern that this is an effort to get a new, cheaper source of labor, which for healthcare professionals to an alternative to paying a physician who's become qualified in the normal way.
Yeah, and I mean, there's a lot to discuss about it. And what hasn't been mentioned is really, in a global perspective, draining other countries of their physicians and the fairness of that. So I won't even go there, but I think it's really important for the process in terms of our ability to have impact. And if anyone's interested, you can listen to that meeting in Tennessee and kind of, again, David probably knows more than I do. There were a lot of missing pieces of information, but it just wasn't a good process at all.
Agreed. And the board chair of Tennessee spoke to that as well, as David mentioned, that they were sort of excluded before the bill had been introduced.
Yeah.
Matt.
Yeah, I pretty much agree with everything everyone else has said. I would just add that the amount of resources that would be involved in trying to ensure quality candidates, especially for a small state like Vermont, it's just ridiculous. I mean, that money could be more, could be better spent simply providing grants to try and get traditionally trained residents here. You know, I think there's huge issues with the sort of social aspects and cultural aspects, as Evan pointed out, and the process, but just even the finances don't really make sense. I don't know that anybody really grasps the amount of resources that go into training a medical student and then making sure that they are of a satisfactory caliber to work within our medical system. And I think trying to have the state do that is it's an enormous process that I really don't think they appreciate the amount of resources that would be involved in it.
Right. We had some interesting discussions with other places who have done this well, like Canada, where they have programs in place.
Mhm.
They're huge. They're national programs that require loads of resources and are very expensive. We talked to New York, who is sort of doing this now, and the volume of people that they have spent an astronomical amount of time and money. I don't know how many licensees I think they have, like 80,000 or 90,000.
I think they're over 100 now, Rick.
Over 100,000. And 100 people. Like, come on. That's not even a drop of a drop in a bucket. It's tiny. So the magnitude of impact is so small given the resource allocation for the programs who are currently doing it. I completely understand what David's saying, and I agree, as well as Pat. Like, I don't think the message from our board can be, this is a bad idea and here's all the reasons not to do it. I think it needs to be hey, if we want to do this well in Vermont, here's the path. Okay, here's how it can be done in a way that's responsible to meet the care needs of our community. And we need to understand the costs of that, because I agree, Matt, it's going to be very costly.
Yeah. And ensuring that patient safety gets the consideration that it should in this whole discussion.
Right. And Dawn.
So I'm sorry, I missed this. When you say they were excluded, who was the they?
The Tennessee board was excluded from all the discussions, and they were, as I recall, at the FSMP meeting, that the chair said that they weren't brought in for the discussion in the state legislature at all.
That's unconscionable. That's all I'm going to say. But thank you for clarifying.
Yep. All right. Last comment from Evan. We got to move on. You're muted, Evan.
I don't think I can satisfactorily represent all LGBT people in this, but I'll try. It took a long time to get where we are, and the idea of having to reinvent the wheel one physician at a time is just awful. Thank you.
Yeah. All right. And with that, David, what's up next? Do you have any other administrative update?
I think that it might be a good idea to go right to, believe it or not, well, we only have 15 minutes. We could go and try and get through some case discussions, because we're going to have a good block of time with these other meetings, or we could sort of tee up and discuss the issues a little bit about the naturopaths in advance of Dr. Moore getting on.
I think the latter may be the way to do it, just to have a little bit of a brief discussion before they join on, because I know there's some stuff that you had sent out to the board just yesterday about this particular topic, and it may be worthwhile just queuing us all up so we're grounded before we start the discussion.
You're too kind to me. I sent it out just this morning. It occurred to me that it would probably be helpful. Not everybody is necessarily familiar with the processes that are being discussed here, and so I sent out what did I send? A copy of the post form, and I think I sent out the statute about the Act 39, which is Chapter 113 of Title 18, the patient choices that end the life. So what exactly is the physician being asked to do? I also looked at, but I thought it was a bit too much. There's a number of different forms for advanced directives for healthcare, and there's a short form and a long form. But it doesn't matter what form you use. On the short form, which is probably the more commonly used one, there is a place for a physician to sign off. It's not a required part of an advanced directive, though. So I don't know if you want to just go over those, Rick, about what's at issue here.
Sure. And I apologize because this is something that I'm very, very familiar with. So if people are less familiar with COLST forms, please ask questions. It's something I do almost every day when I'm in clinical practice, as it comes up commonly in the hospital. But the advanced directive documents within the state, there's a handful of them, but the COLST form specifically is the out of hospital DNR form. This was something that was recently redone. Like, it took them years to finally rewrite it because it was a bit of a nightmare. You had to sign it in 3 places and twice on one page and another time on another page, after there was a lot of meeting amongst the healthcare advocates around the state to get the wording and everything right. It's a really important and complicated process involving multiple discussions with families and multiple team members, frankly, involving physicians, nurses, palliative care team members, that sort of thing. Unfortunately, of all the documents that we have to review, it's one of the ones that is most commonly filled out incorrectly. There's a lot of times where people will not understand, healthcare personnel will not understand how to fill it out right. And if it's something that people don't do often, it's easy to fill out wrong, which is part of the reason that it was modified recently. There's a lot of people who have full code COLST forms, which really doesn't serve much of a purpose in most circumstances. It's intended to be a document that documents someone's wishes to limit care in some manner. And you can read it yourself, but there's a lot of information in the second page of the COLST form around specifics around it, but I can tell you many people do ignore those. So I see it routinely filled out in ways that has to be clarified all the time in patients I see in the hospital, because there's conflicting information within it, or care that's being provided that's in contrast to the COLST that's being provided. So again, it's something near and dear to my heart, and something that we can't educate enough about. We do it at least one educational session a year here in Rutland to help people, healthcare providers, fill these out correctly. Any other questions or comments, Pat?
Yeah, I read through the COLST. I'm familiar with that too, but also the patient choices at end of life. And I did note that, and I have to say I've read this before, but it kind of sunk in a bit more now. The term used is physician, not even PA, not NP, it's physician. And then it actually defines physician by Vermont statute 26 VSA chapter 23 or 33, which is a MD or a DO. So is that correct?
That's correct, Pat. And so the reason why we're discussing this is because there's the legislature was, had the naturopaths coming to them and saying, we should be on this. And there's, some patient advocates who like using naturopaths who support that too, and legislators who are interested. And so they've talked about this on and off for years. This year, they decided, you know what, we're going to require a technical advisory group to be convened by the commissioner of the Department of Health to bring in interested parties to discuss this and to make recommendations or to the commissioner, who's then going to, submit recommendations to the General Assembly, the Healthcare Committee in the House and the Senate Health and Welfare Committee. And so
that would require a statute change of this statute. Should that be the recommendation and the decision? My thought about this is that the line of thinking is that a naturopath works as a PCP, so they should be able to do these additional activities that are part of primary care. Yet it's just kind of interesting in thinking about it. I don't know why NPs and PAs, who also work as primary care providers, were not in the original, in this existing bill about choices at end of life, were not included. There must have been a reason for that, or there must have been some discussion, and I don't know what that was. I was just, because they have a lot of experience. They certainly have, the PAs and NPs have in-hospital experience. And so I don't, David, do you know what the history of this was?
Vaguely, I wasn't involved in, much at all with the process, and I believe it probably had to do with just, the significance of what's at stake, and wanting to, they wanted to set the bar higher, that it needs to be a physician has the highest level of practice, and not a mid-level provider. And I think that's certainly something that could be pointed out, is that, this is not something that less trained individuals were included on.
Yeah, exactly. That's my point. But I just wanted to be kind of open thinking about it, but I didn't know why it was written with excluding those primary care providers.
And it's not exclusive to this particular clause in our laws that explicitly state that physicians. So the one thing this sort of makes me think of, and again, wearing my inpatient hat, but the Inpatient Bill of Rights for patients specifies that a patient has the right to receive care by a physician, not by a healthcare provider, not by an APP, by a physician. And this is written in the same language, right, where it's saying that this is done by a physician, and that change can be discussed, but it is a change in the way that we practice care in Vermont.
And the hospital regulations require every patient who's admitted to be admitted by a physician, a DO or an MD. But, no.
Kinda.
There's one designated in the process. It may be an APRN or a PA who's doing the paperwork, but technically there's somebody who's on the hook as the admitting physician, right?
Well, there's some debate amongst that, and many hospital systems, JCO or the Joint Commission has a slant on that, and CMS has a slant on that. The only thing in Vermont is the Vermont Inpatient Bill of Rights that stipulates physician. The federal laws in this are a little more squishy, because it doesn't explicitly say thou shalt have a physician. And if it's okay, it doesn't matter. We're getting down a rabbit hole. We got a lot of people with their hand raised. Margaret.
Just wondering, are we reviewing the coast form or it was just informational? Because I didn't see it in the board packet.
It
wasn't.
It wasn't in the board packet. I emailed it out today because I thought it might come up. Just, what are they being asked to do? And so I thought that might be somewhat helpful for people to see what the physician's role is with the COLST form. If you're going to be asked to come to a decision about whether or not you want to make a recommendation to be provided to the technical advisory group. And the other thing I should mention is, we're talking about these. I think we had already talked. We never really got to the punchline, but we had talked a little bit about the death certificates and whether or not they should be allowed to complete a death certificate and the advanced directive form, which again doesn't require a physician's signature. Though a physician can be involved in counseling patients. It seems I don't. My thoughts shouldn't drive the board's position, but it seems like the DNR COLST and end of life ones present a situation where one might think that it's more important that the patient be guaranteed access to somebody who is fully qualified to counsel somebody about the treatments that are available and the things that a person should be able to know when making these kinds of decisions.
So to interrupt, sorry to cut the line, the instructions don't specify it needs to be a physician. The third page, the first line says the clinician can be an MD, a DO, an APRN, a physician assistant. So.
Oh, that's on the COLST form, but yeah, we were talking about where it requires an MD or DO is on the patient choices that end of life.
The statute indicates that it must be a physician. The COLST form says it can be others. That's why there's a discrepancy and something that needs resolution. Matt.
That was actually going to be my question because I couldn't understand what Pat was talking about because I'm reading that clause that says clinician. And then when I was flipping through the other document that he sent out, I can't find the part that you're talking about that requires a physician. I will clarify that in a second. That being said, I don't know. I think we need some internal consistency. If we are considering naturopaths to be primary care providers in this state and provide primary care, death to cradle care about all these other things, talking about death and dying is part of that primary care process. And I don't think we can separate the two. I think we need to make a decision. They're either allowed to do it or they're not. I don't think you can break out, oh, you can only take care of certain parts. I mean, death is part of healthcare. And if they're going to be allowed to prescribe antibiotics to treat infections, and one of the potential consequences of an infection is death, then I feel like it's part of the whole package. And I might disagree with naturopaths on a lot of their different philosophies and particular treatment schemes, but I think if we've decided that people have the choice to undergo that type of healthcare, then they shouldn't have to go seek out a separate practitioner, clinician, simply to talk about what they want when, the end of their life is near, or preferably it should be done long before that so that the goals are clear should an accident happen or whatnot. I think that if we allow people to have in this state and they've accepted naturopaths to be primary care, then it is a disservice to those people to not have this as part of the package. Say they're, even if they're like a 35-year-old that's healthy, but they get involved in a horrible motor vehicle accident. If we're not allowing this group of practitioners to be involved in that discussion, then we're missing, but frankly, at least in Montpelier, a fairly large group of people that aren't going to have these things on file. And when they show up after, you know, a devastating injury or brain bleed or whatever in the ER, and I don't have that information available, it's a disservice to them and their family.
Matt, do you think, and I think we'll find some of this out, but do you think
I
that
just want to let you know,
naturopaths
Rick.
understand? Yeah.
Dr. I'm sorry to interrupt, but Dr. Moore, I just want to let you know, Dr. Moore is in the waiting room. So.
Okay. Just one more minute and we'll let him in. But do you think naturopaths have understanding what a code means? Success rates, when it would be a successful endeavor, what the outcomes are, those kind of things. I think, at least
I'm
for
not
me.
sure that most of the physicians that are filling it out really do either.
Sure. And
So
to that point,
I think it just involves more training and more, but I'm not saying I necessarily agree, but we need to be internally consistent and making somebody have to go see. I mean, what are the chances that all the people in Montpelier that have a naturopath as their primary care can get an appointment with anyone else simply to talk about a COLST? Now, if the state wanted to provide, COLST clinicians that they pay to specifically go and meet with everybody, that's a different ballgame. But we've encumbered this group of people to take care of a certain amount of the population. And with Medicaid, it's not an insignificant number, at least not around here. There are a lot of people that very much prefer. And so I'm constantly navigating that. Well, my naturopath said to do this, and I'm in a different ballgame. And I'm very open about saying, this is not something I'm familiar with, this particular treatment, this herb or whatever. And I'm also very comfortable having those discussions about, end of life. And I think that, I just feel like we have to be consistent, and it's a huge part of healthcare talking about death. And I think that not giving them that privilege is a disservice, and that means the conversation's not happening. Because I don't think other people are going to be able to have that conversation if they're not doing it.
So, Rick, this is, I should say something because this is a public meeting and I should let them in.
Yep, that's fine.
Okay.
Are you waiting? Oh,
Well, welcome to our new attendees. Rick, did you want to?
Yep. Would you, for the folks who just joined, would you be able to please introduce yourself and just let us know who you are?
I'm Stephanie Winters from the Vermont Medical Society.
Hi, Stephanie.
Stephen Moore, naturopathic physician, legislative chair for the Vermont Association of Naturopathic Physicians.
Welcome.
Heather Scholdice, William Scholdice and Associates, and I'm here with Dr. Moore today.
Great. We were having a brief discussion prior to your joining, and David, are we having a presentation? Are we having a conversation? What's the format of this?
The plan was that we were giving Dr. Moore an opportunity. That the board, in the previous discussion, the board had indicated that one of the things they'd want to know if they had to make a decision about this would be more information about what the required curriculum for an accredited naturopath program includes, so that we could better understand how they might be prepared or not prepared to engage in the processes. And so this was offered as an opportunity to the Association of Naturopathic Physicians and Dr. Moore to come and present information about that.
Great. Dr. Kader, if it's okay, if you could hold your question until after we have Steve here give us our presentation, we'd really appreciate hearing some information, and then we can go back to the questions that we might have. Does that sound okay,
Absolutely.
Everyone? All right, take it away.
Yeah, thank you for the opportunity. Thank you, David, for inviting me and your time. Happy to kind of give an update as to our legislative asks and the current process involving all stakeholders to kind of vet this and make sure everybody's on board and everybody has a say in the process for what we're after. And I don't know how much everybody's aware what our asks are. So I don't want to assume too much, but also I know we have confined about a half hour. So I'll just lead with, I came into the role as legislative chair a little over a year ago with that, taking legislative priority, trying to make sense of things that were priority versus not, and was there a narrative behind these things? The narrative really that was teased out with the items that remained. We're looking at what are we not able to do? What are we being asked to do from time to time? And in our role as primary care providers in the state of Vermont, and how do we achieve what we're calling primary care parity in the state? And with that, the items on the time were being able to formally be recognized to sign off on birth and death certificates, to be able to sign off on DNR and complete COLST orders, and to be able to participate in medical aid and dying in the state of Vermont. And part of that was, again, due to our members of the VAMP as providers in the state from time to time being asked to participate in these things, and having patients and families in peculiar situations where we're not able to participate. So we're trying to onboard these patients to other providers who can help comply or at least comply with the wishes and requests of the family or the patient. And looking overall at the statute, realizing that our other primary care colleagues were able to do these things already. And that includes, as you already know, medical doctors, DOs, nurses, and PAs as it relates to DNR and COLST. With that, through the last legislative session, we were able to achieve recognition, or at least have our ability to authorize and sign off on birth recognized in HA70. It was agreed upon at that time between the VAMP and stakeholders, and to create space, a number of meetings where we would have this out, discuss, and then at the end of this, ideally by November, December.
Is everyone else having a hard time hearing Steve here? Because I'm
able to
getting
create.
Yes.
Dr.
Steve,
Moore, you may want to
My
try.
apologies.
Maybe if you turn your camera off, sometimes that helps with the bandwidth.
Okay, that's done. And what I'm going to also do is just out here, you're able to hear me better at this point.
not sure. It's still a little bit broken up, but maybe try talking some more.
What I'll also do, let me try and just hide everybody else a little bit. Why don't I try that? Testing better.
You do seem a little better now, though.
Better.
Yep.
Okay. Okay, so I'll, where maybe I left was the formation of this technical advisory group, number of meetings, stakeholders involved, and at the end of it, sort of a general summary of various positions of the stakeholders, for which that would go back to the General Assembly and help form whether or not and to what degree legislation would be enacted. And so with that, we've had 2 meetings in this group, this technical advisory group. A third meeting is scheduled for next week. And there have been a number of requests and asks that led with the conversation's been focused on specifically training of naturopathic physicians, and what does that involve and to what degree, and being able to look through that and see and determine if that translates in being able to participate in our current legislative asks. What I've done and submitted to the legislative, the technical advisory group, Per Lauren Lehman, the documents have to go through her. There's closed meeting rules, but I have submitted, David's probably seen them, or at least the email. I've submitted curricula and some syllabi from most of the naturopathic medical schools in the country, and that is there. There was a response from Betsy Walkerman from Patient Choices Vermont, I believe as of yesterday, and it seems like they would like me to go through that in more detail and actually make markings there. OPR initially had asked for syllabi and course materials, which is why I submitted this. And ultimately, I think what I'll do is I'll just kind of stop there. I'm happy to take questions. I'm also happy to speak additionally and further why I think we should be brought to the table, so to speak, and increase our ability to collaborate with our patients as primary care providers in the state. I'm happy to do whatever you feel is best with the time we have.
Can I just start with one question that I've heard from a variety of people, and it does speak a little bit to training and education, but you had mentioned, the syllabi and such that you had submitted. To what extent are naturopaths trained in codes and what the resuscitation process is? Is that a typical expectation to be participating in codes in a medical setting and understanding the sort of process there?
Yeah, great question. And that really kind of harks at where things are left off. And so in terms of our training in this regard, we don't have that level of training. We also don't have, as David had asked in the last meeting, we don't have a mandate regarding residency. And there's not a requirement to have any of those residencies or clinical training in a hospital setting. Although that exists, it doesn't have to.
And sorry, just as a follow-up, would your thought be that to meet this need, there would be education or training to try and understand those processes better, or not?
And it's a great point, and really to the heart of the formation of the technical advisory group in H870. I think the thing that we're also interested in, to your question, is what would it need to look like? Realizing, and to be very frank, our training is not a carbon copy of MD or DO counterparts. I'll just say this as well. There are states, as I'm sure you all know, or could recognize, there are states where mid-level practitioners have this authority, and they do not have that level of training as well. So it would be teasing that out in a good faith, highlight what is an expectation and what would be reasonable based on the current precedent that currently exists. If I may, to this point, I had a conversation with one of the executive directors or board members, I should say, in New Mexico, and with their mid-levels that they had, right, we're not mid-levels, but with their mid-level practitioners to participate in medical aid in dying, one of the conversations that they had was around having the attending clinician, the requirement be that they be a medical doctor or DO. I also want to highlight that the requirements for medical aid in dying require determination. Well, I would argue as primary care providers in our training as such, according to our accrediting and educational bodies, we are required, we're training to diagnose. But the point that I'm trying to make here is we do that day long, and I believe we could determine the fact that there is a terminal diagnosis. They are able to self-administer medication as examples, and to be able to collaborate with other providers like we already do on a daily basis. So in short, I'm very interested if there is hesitation or there is an interest in looking at what that training would look like, what that discussion, here's what it should be, or here's what's missing. Well, how do we reconcile that? Yep. Within the vein of really trying to help as many Vermonters as possible.
Great. I'm going to actually go to Dr. Kader first because he had his hand raised from before and we cut him off. So we'll start with him.
Yes, I had some questions and some comments. I'll hold my comments for our anticipated later discussion. But my questions, in the materials we received for the meeting, I did not see detailed information about what naturopathic education includes. And I wonder if Dr. Moore could take us through a curriculum from high school on, after high school graduation on, in terms until a naturopathic physician becomes a graduate. Secondly, my understanding, and I may be wrong, is that in Vermont's law, a naturopathic doctor is a physician by law. Is that correct, or is that a misunderstanding? So I'd appreciate if somebody could address those, preferably Dr. Moore,
That is
address those two
correct.
questions.
The
We are
Department of Health
not,
about the closed meeting rules.
we are
go
we are
ahead.
not hearing you anymore, Dr. Moore, at all. I think there was a huge gap.
Testing. Can you hear me okay?
It's better. Yes.
Okay. So my apologies down here in Brattleboro. So what we're getting at, to your point and question, we have the materials. I wasn't sure of closed meeting rules. Those have all been released to Lauren Lehman from Department of Health. David has a copy of it. I know it's been disseminated. I just wasn't sure because we haven't met since the group meeting. I wasn't sure. I'm happy to furnish all of that. I just need to make sure we're okay on that. So in short, I'm happy to release all of that information to the group. I just need Lauren Lehman to sign off on that.
I think that would be helpful for many
the
folks.
curriculum, or at least, of course,
Yeah,
absolutely.
but
Go ahead. I'm sorry.
I was just going to say, I hadn't shared that with the board. I just got it last night or this morning, and I didn't think it would be helpful to send the members 600 pages of various curricula from different schools. I was hoping that we could get with MDs and DOs, their organizations that create required elements of the curriculum for training, and that if there was something like that for NDs, that would be really helpful.
Yeah, and that does exist. Lauren does have that. I can definitely prod her along to release that. That was issued with the second group meeting that we had, which is the core competencies document from the accredited Academy of Naturopathic Medicine that lists that out very similarly to a lot of other professional groups. So that exists. It's roughly, just spitballing here, I want to say it's probably a 20-25 page document. And the larger, more voluminous is just to give you as much information as you like. I know it could be overwhelming, but I also want to be very transparent. So you could see from a number of schools from start to finish what the curriculum is and also make comparisons. But I'm also very happy to resend and reissue the core competencies. And if Lauren, I'm going through Lauren's final, that issue that to the medical board here.
Okay, let's move on to Dr. Tando because we do have a lot of people with their hand raised. Margaret.
I had a similar question because I didn't understand what your answer was when the question was asked about the code training, and you said like residency is not a mandate. I mean, what does that mean, that naturopathic physicians don't do residencies? Is that what that means?
Yes, naturopathic physicians are not required to complete a residency, although they exist after graduation. They range from anywhere between 1 to 3 years, and they're throughout the country. Once you graduate, though, from naturopathic medical school, that is not a requirement to license.
Okay.
practice.
How long is a naturopathic physician training?
Outside of, after college, it's 4 additional years.
No. What to get a naturopathic physician outside without the residency? How long is that? How long is the schooling?
The schooling is 4 years.
4 years. Okay. That's after college or after high
Yes.
school? Because that goes back to Dr. Goodaire's question again.
Yeah, it's after college. Yeah. So in order to be able to matriculate into naturopathic medical school program, and they're very much like probably most medical training, there's a number of prerequisite science courses. So if you're, as an example, if you're an English major, there's a certain number of, pre-med, if you will, courses to take in order to even apply.
We are still having a bit of a challenge with your audio, Dr. Moore, but I think we understood it. There's some prerequisites prior to starting naturopathic school. You would get a bachelor's degree from undergrad, and there's some pre-med type courses, and then 4 years of training after that.
Correct.
Okay.
Correct.
Peter, Dr. Ireland.
Hey, Dr. Ireland, primary care. I'm a medical aid in dying prescribing physician. I take part in Act 39. And my question is about the naturopath's ability to prescribe these medications. It's a cocktail of medications, kept pretty close to chest for obvious reasons, but it includes controlled substances, opioids, benzodiazepines, barbiturates. And I was looking over the naturopathic ability to prescribe controlled substances, and it's allowed in specific circumstances in Vermont, but only for natural medicines produced by nature, not artificial, not man-made. So I don't think phenobarbital, diazepam would fall under that umbrella. Would a naturopathic physician be able to even have the prescribing authority to be the prescribing clinician for medical aid in dying here in Vermont?
Dr. Ireland, I think yes, we can. Our scope, if you will, was updated about 10 years ago. And so for naturopathic physicians who wish to prescribe legend drugs, including controlled substances, there's a specific testing that you have to do. You have to pass the test, and then you have to apply for an endorsement to your license. And that allows for the prescription of medications, including, as you were just outlining, those medications, controlled substances that would be a part of medical aid in dying.
Okay. Gail.
Yeah, so we're struggling, and it seems to me that after all this time, somebody must have done a chart of the difference between the training for a doctor and the training for a naturopath. And if there is such one, could you provide it to us?
Absolutely. Again, we provided that to the group. I'm happy to have petition Lauren to release it. I'm assuming that won't be a problem. And we've got a number of documents too that I can easily think of that are simple, very much a page synopsis and doing comparisons.
Okay. Pat.
Thank you. My question was largely the same as Dr. Ireland's question, but just to add on to that, I'm assuming that the naturopaths who do this additional education and get an additional qualification on their license for prescribing controlled substances, I'm assuming they also have a DEA. I just wanted to follow up on that.
Yes, we do. For those that that fulfills, obviously, to be able to prescribe controls, yes, we have to.
Okay, thank you.
Procure
David,
a DA.
again, Dr. Moore, I think we're the audio is cutting out. We're getting, I think, most of it, but sometimes there's big gaps. But I believe basically the answer was yes. Dr. Kader.
Yes, yes to a DA. We do have it. Yes.
Okay.
Yeah, I just want to restate my original question. Number one, is a naturopathic doctor legally a physician in Vermont, according to Vermont law? Number one. And number two, I really don't need a 25 or 600 page summary, but exactly how many years of training does a naturopathic doctor get after high school? Some of the cutting in and cutting out may have, I may have missed some of that, but once through high school, is it my understanding that an ND goes to 4 years of college, then takes prerequisites, or during college takes prerequisites, and then spends 4 years in naturopathic school? Is that correct?
That is correct.
Okay.
Yes.
Thank
Really, I'm sorry if it's cutting out.
Does anybody know the answer to David's first question about the Pat's raising her hand? Pat, do you know the answer to that?
Well, I would just, again, this is what I brought up on the wording in the statute for end of life choices, is that in that statute, it specifically says that physicians are given the capability of doing this, and it says physicians as defined in 26 chapters 23 and 33. Chapter 23 is the MD statutes, and 33 are the DO statutes. So it really excludes PAs, NPs, and naturopaths as that law exists now. So that definition of physician in that document is an MD or a DO.
Is there a different statute, so not VSA chapter 23 or 33, that defines naturopathic doctors as physicians?
Yeah, they are called it's the chapter for naturopaths is chapter 81, and that is under OPR, and chapter 81 naturopathic physicians.
Okay. I don't know if that fully answers our question, because I don't know.
No,
if
it doesn't.
It's like there's different
But
definitions of the physician in the
Yeah.
statutes, which is super confusing.
Well,
But
and all of you raise a great point into our frustration is, at times this is called a scope expansion. You can imagine our confusion just trying to get clearer, because there's certain things we're allowed or we're expected to do. And in other cases, at times it can be confusing at best, and other times it's frustrating, where it's like, well, are we excluded? Yes or no? So we're looking to update this. And this is the prime example is regarding DNRs. It's not clear in the language, and we had one of our members, request to sign off on that for a patient, and it was denied by Department of Health.
okay, great. Scott? You're muted, Scott.
Oh, there we go. In terms of naturopathic medicine, would you be particularly or typically working alongside conventional medical practitioners and providing what is called an integrated care for patients? It sounds like you would be completely independent.
Dr. Moore, did you hear that question?
Yes. My response is, are we talking generally? Are we talking specifically regarding medically dying.
Well, I'm just asking in general, I'm trying to understand the differences between physician and naturopathic medicine.
So I think it was a more general
If
question.
it's helpful, at least, yeah, if it's helpful in my practice. So I'm independent primary care doc in Southern Vermont, in Brattleboro. I have my own patient panel. I see, basic, age range from neonatal to end of life in terms of when they transition onto, hospice as an example. And I see a range of things in my day. I don't, to some people's questions, I don't have to have a collaborative care agreement with anybody. I don't have to have, quote unquote, some sort of oversight from another physician. We act independently, like physician assistant.
Thank you.
Maybe, I don't know if this is where Scott was going with this, but it might be, Dr. Moore. So I'm, obviously I work with folks who have naturopathic physicians as primary care physician. I'm an inpatient medicine doctor. Would you say it's routine for you to have allopathic medicine physicians also involved in the care of your patients?
All the time.
All the time. Yeah. So specialists and those kind of things, right? Sorry, and we're really having a hard time with your.
And for a number of reasons. Yeah, all the time. My office is right next door to the hospital, and whether it's labs, imaging, advanced imaging, specialty consults, coordinating consults, trying to push a consult sooner rather than later. I have support staff that help me with that, but without it, I don't know if I'd see any patients because I'd be on the phone all day. But it's never ending and all day long that we are constant in collaboration with other providers and organizations.
Thank you.
Great. All right. I don't think we have any more questions, and I believe we are at our time here. I greatly appreciate that input from Dr. Moore. And David, are we going to be discussing any kind of recommendations? I think for me personally, I'll speak for myself. I'd really like to review some of the documents that we were discussing, curricula and that sort of thing. I don't feel necessarily comfortable personally making any kind of recommendations to anyone without reviewing that. But is there a need to make a recommendation in a timely manner?
Yeah, I don't think we could hold off until the November meeting. We would not be in time to provide input to the technical advisory group that's going to be meeting in the near future. And double check the calendar, but it's during October for sure.
And again, I'm happy to ask Lauren to release any information to you that would be helpful. Happy to do that.
When is that next meeting, David?
I'm looking at my calendar now. It's next Tuesday. It's from noon to 2:30 on Tuesday, the 8th.
Stephanie just put in there, I think it's the 8th.
Jeez. How would people like to proceed? Again, I don't know that I personally feel comfortable saying much without having a little bit of a better understanding of some of the again, I think my bent is, and I think Matt has articulated this best. If we're going to empower our naturopathic physicians to be primary care physicians, we need to make sure they can do that. I don't know that we've provided the level of education that's required. I don't know. And is there a need to do that? Maybe. But it would be hard, I think, for me to say one way or the other. Any other thoughts or comments? Did anyone want to make a motion?
Yeah, there's no way I'm going to make any decision today.
Yeah.
I need more information. I'm not informed enough to say yay or nay.
Yep. Matt?
So Dr. Moore, Matt Greenberg, I'm an emergency physician here at Central Vermont, and I'd say that one of the concerns that I think that I have personally, I feel like if you're empowered to be a primary care provider, then talking about death is essentially part of healthcare. It needs to happen. It has to occur. From sort of the more cynical perspective, I see patients day in and day out that are sent to the emergency department with horrible illnesses and complete lack of understanding of what they want as they are approaching their death. And I see forms that are continuously inappropriately filled out, not filled out, inconsistent with their medication lists. Just, they're not the powerful tool that they could be, and they're not done appropriately, and they're not done necessarily in the best interest of the patient. So I guess I would favor more education to everybody that's already doing them. But especially if we have a whole new group of people that are taking them on, and part of understanding how to fill out those forms is also understanding what's going to happen at the end of life. And I think this gets a little bit to what Rick was talking about, understanding what happens in a code. And I imagine there are a lot of primary care providers that don't, but I can tell you how gruesome it is to resuscitate an 89-year-old who weighs 80 pounds because somebody filled out a document that says, they want everything done. Now, frankly, within my capacity, I can say, I can fall on the futility of care because I know that the chances of resuscitating that person to any semblance of their prior existence is less than 1%. So we have to make difficult decisions day in and day out. But having that information, and more often, it's more important for the families than it is for the patients themselves. And to promote those discussions about end of life care and dying and what that process looks like, I think it will involve perhaps more understanding from your perspective and your training. Because I think most of us don't understand exactly what kind of training you have regarding end of life. And I think that's why a lot of us are hesitant to make a call one way or the other. But if we could build a package of saying, this is what happens, this is, maybe some videos or whatever, and really make sure that people understand that filling this form out is really important to us in the ER and other people that they're going to see near the end of their times. And, it's such an important aspect of this that I think a lot of us are resisting because we don't understand what exactly you could bring to that conversation. That's sort of where I am at.
Matt, I've often thought the same of our patients, to be honest. If there was ever a very skilled filmmaker who could actually film a real code, not a soap opera code, I think that would be so valuable for so many people. It doesn't take many codes of someone with esophageal varices to just be, horrified about what we do to humans in the last moments of their lives. And again, some of us live that often and others less so, but I share everything you've just said is spot on. The forms being frustrating and not serving patients, and the lack of knowledge by so many is huge. And again, same degree of reluctance that I think a lot of folks have, just because I want to understand more and we want to do this right. Pat.
Just in the interest of how to proceed, it sounds like people really would like to have time to read these materials and think about what their best recommendations would be. But we have a deadline of next Tuesday. Is that correct?
Well, yeah, I think from a practical level, if we don't have a decision today, I just don't think it's going to happen. And the ability to call a meeting and conduct a meeting, I have obligations tomorrow and Friday that are really not flexible. I don't see it happening, but
Monday.
I mean, could we
if
do
members wanted to call a meeting for Monday, I don't know if lunchtime would work for people. I'm throwing that out there just as, thinking that might find more people available.
I could make Monday work. I don't know that that's a great solution for everyone here, but I truly, I feel the same as Margaret. I have a really hard time weighing in on this. This is a pretty important topic without educating myself, and having the weekend would make me feel a lot better before making a motion. Pat, do you have another suggestion?
No, I was just going to say I could make Monday work, and maybe for those who absolutely cannot make Monday at noon, even for 5 or 10 minutes to get a chance to say their viewpoint, they could write in some points, and we could do it that way.
I was thinking the same thing. If people would be willing to write their thoughts, we could read those and discuss those. Dr. Kader.
Excuse me, Stephanie Lorenz. Stephen, can you get that information to us right away?
Yes.
I sent out, I think I found what Dr. Moore was referring to. There's the AANMC core competencies, and I sent what I believe is the most recent one from their website. It's a 14-page document.
If there's a possibility to get the other things that he was referencing that went to the committee, I think that would be helpful as well. I mean, just a tip for folks, there's ways to summarize these documents that doesn't require you reading 600 pages.
Yeah.
Tools.
Thank you.
GPT.
Thank you. Thank you. I'm also happy to ask Lauren and just confirm, and I can get that done tonight. So my point is I'm happy to force this along for you guys.
Great. David Kader.
Yeah, I did read the works cited link on the material we got, but it still was fairly general information. FAQ1, how are naturopathic doctors educated, trained, and licensed? Monday would be a problem for me. I just wonder if we could deliberate it to some degree today if we already have a meeting going on.
My concern is, again, I don't think I haven't had a chance to review all the documents. There's a lot of documentation on this that I'd like to review that I think will take more than 20 minutes. I think it'll take a couple of hours of my time on the weekend. That's my personal opinion, but if others disagree. Stephanie, you still have your hand raised with that question already answered?
Oh, no, my
Gail?
question was answered. I'm not quite sure how I turn it off, so.
That's okay, I can do it. Gail?
Okay, thank you.
Yeah, I can't.
Two things. If we are going to be commenting, could somebody review the questions that we're commenting on? And the second, I just looked at what David sent us, and it is so loosey-goosey. It does not tell me anything about the skills that a naturopath has or doesn't have compared with a physician.
Yeah. Again, I think the document that Dr. Moore was referencing was far more detailed and comprehensive in some of those things. Is that correct?
Yeah, it's upwards of 600 pages, yes.
Don?
Well, there's nothing
Sorry,
in
Gail.
between actually says what this, I mean, these are like attitudes and beliefs or ways of being, but they don't tell me if you can do heart surgery. They don't tell me if you can treat COVID. I mean, they don't tell me what the specific skills that a naturopath would have.
Yeah, what David had released was just our sort of written testimony that we gave, but the actual requests through the technical advisory group regarding training, just because it's not clear about closed meeting rules, that has to come through Lauren, and she has that, but I can ask her to release those things. So it understandably is going to be very vague what you're seeing, but I just can assure you there's a large volume of material that we're happy to release.
to Gail's point, Gail, by statute, naturopathic physicians are prohibited from performing surgical procedures except for episiotomy and perineal repair associated with naturopathic childbirth.
Dawn?
So I will not be able to make a meeting. I have another meeting on Monday, but as a member, as a public member, I just want to acknowledge and thank this group for paying attention to this issue. I think the end of life is a very important phase of life and people need to be trained. However, similar, well, the conversation about NPs and nurse, physician assistants. I have been a very healthy person, but so my relationship with primary care is with a nurse practitioner. And I have a relationship with her. And if I were to be seriously ill, I would want her to be the person I talk to. Would want her to be the person who talks to my children about these things. But I also want to make sure that people who are enabled to do this at the end of life, including naturopathic physicians, have the appropriate training and understanding and know what it's like to resuscitate people and what the risks are and what the experience is like. So thank you for paying attention to this very important issue.
Rachel.
I put my hand up. Okay. I guess I have a couple of thoughts and maybe a couple of comments. I'm not sure I have a question. Actually, maybe I do. Dr. Moore, the practice that do you have a typical, is there sort of a run-of-the-mill naturopathic practice?
I may be an outlier in this regard. When I started almost decades ago and in medicine, but also in private practice about 12 years ago, a lot of patients that would come to me assume because I was a naturopath, there was a certain sort of toolbox, if you will, that I was going to, adhere to or that I was going to promote. And to some patients' chagrin, people would come in with a condition, and I would let this list of herbs or this dietary supplement's not appropriate. We need to do X, Y, and Z, or get you to somebody else, or do this testing, or maybe we need to use an antibiotic. And so to answer your question, though, my typical day, I'll see a wide range of things, and I think what I pride myself on is I'm really not adherent to, or identify with a particular therapeutic. It's, what's the most appropriate thing based on the evidence, and if there's wiggle room to add anecdotally has been helpful, or there's some evidence in the literature that it could be helpful, but and we've got the time to do these things, then I will offer it as an option and allow the patient to decide. So my practice, though, if you were to come into it and look at it, you may not really be surprised at what I do or see it as any way different. I do emphasize diet when appropriate a little bit, probably a little bit more. That's also a testament to my training, and also I'm more open to alternatives. But I don't pretend with patients that an herb is better than a pharmaceutical agent, or that we can skirt around the appropriate testing or screenings just because the latest greatest supplement craze is out there, and we need to be doing whatever that is. So hopefully that's helpful, and hopefully I didn't break up too much.
That's very helpful. I guess and this may be my own ignorance, I kind of think of naturopathic medicine as being a lot of preventive care and well care. And I am very familiar with working with patients on completing pulse forms, and around end of life, I do palliative medicine at Central Vermont. I I am less concerned, and this is more to our whole group, I'm less concerned about adding more people who can consider filling out a COLST with someone. With medical aid in dying, I guess I have a couple of comments. One is that prognostication can be really tricky in some of these cases. There can be disagreements, and one of the stipulations, so it has to be eligible for medical aid in dying, you need a prognosis of less than 6 months. One of the stipulations to prescribe is that your patient is making an informed decision, and if you're not really familiar with all of the treatment modalities that are available to that patient, it's hard to attest that they're making an informed decision. That would be a concern of mine around expanding the prescriber pool for medical aid in dying. I think that's all I have to say. Open to receiving comments.
Ian.
Hi. Oh, hi, Dr. Moore. This is Ian. I have a quick question. Do all naturopathic doctors have a DEA license?
Great question. It is not required. It's required if you have your endorsement, you're going to be prescribing controlled substances.
Then to follow up with that, from what Dr. Ireland said earlier on, that there are some times you might need to prescribe controlled substances during end of life. So how does that work? Does all the naturopathic doctors get that privilege, or just those with the DEA license?
Yeah, in Vermont, you would have to obtain the endorsement, and then obviously apply for and garner the DEA license. So we can do it. You would just, in order, understandably, to participate in medical aid, right? You would have to have those criteria met. But the short answer is but we are eligible and able to do so.
So in such a situation, who would the privileges be extended to for that end of life?
I would imagine, we haven't gone to this level, but I would imagine, right, a requirement for participation would be, at least in the state of Vermont, right, you would have to have gone through the training, taken the additional testing, passed that testing, obtained your endorsement to prescribe, amended to your license or affixed to your license. Those are all the hurdles that you would have to jump through, right, or achieve in order to even be considered eligible to participate in this. That's a great question, great point.
All right, thanks.
All right. I apologize to our guests who we were supposed to start. The next conversation could have been earlier. Again, I think I don't have a great solution here, but I think the best proposal I've heard is to try and convene a group of us on Monday to retake up this and make a recommendation, unless people feel comfortable in voting on it now, which I have not heard that people are. So perhaps we can have an opportunity to review some documents through the weekend and convene on Monday. Judy. You're muted.
I'm sorry about that. I lost the screen for a minute. I like the idea of trying to meet on Monday, and perhaps those who are unavailable on Monday could, if they have time, put together a note to send to all of us that we could include in the deliberation on Monday.
Agreed. I would ask that of everyone who has some time. Obviously, if you have clinical responsibilities and can't do it, we understand it. But if you're able to review documents, hopefully we'll get those soon and try and meet with who's ever available on Monday. And if people are not able to make it, if you could share some notes, we'd appreciate that.
Just to clarify, for those who can't participate, they could provide some thoughts, but we can't have somebody vote by proxy.
Correct.
And I just sent everybody, there was another file, I think Dr. Moore, I copied you on it. There was another file with had 700-page document that's the National University of Natural Medicine course catalog, and then a 10 MB zip file with a bunch of different documents. Is that what you were talking about? You're on mute, Dr.
Yeah, that is it. And that's what I was just waiting on permission from Lauren to release. That's one of the documents.
She had sent it out this morning. I got it. I'm sorry, I was in the licensing committee meeting that started before this meeting, and I did get it at 10:30.
Okay, David, is there a way we could have that not emailed? The zip files are blocked by many professional
Oh,
organizations.
okay. I'll break them open and resend it.
Thanks. All right. I think we'd all like to say thank you to Dr. Moore, and more to come next week.
Thank you, everybody, for your time.
Thank you. Next up, we have Vermont Medical Society and VPIP. We were going to connect with Dr. Clouster and Jessa, which I think I saw her on somewhere. Yep. Did
Good
we?
afternoon.
Again,
Yeah. So go ahead.
what was the format for this one? Is this? Did you have some words prepared, Jessa?
We did not have a formal presentation, but I think our goal is just to introduce ourselves, give an introduction to VPIP especially for some of the new board members. But I also want to make sure we have a couple other folks on as well. We have John Valentine, who's the chair of our VPIP committee, and I believe, I don't see her camera on yet. We should have Colleen Magny, who is the program administrator. Let me see if, oh, yep, I see Colleen. She just wasn't on my first screen. Yeah, so maybe folks could introduce ourselves, and then I think Colleen and Nels will kind of lead the introduction.
Perfect.
So Colleen, do you want to go ahead and introduce yourself?
Sure. I'm Colleen Magny. I've been with the Vermont Medical Society for 19 years, and I've been doing the Vermont Practitioner Health Program for just as long. We've seen a lot of changes over the years and are thankful to be able to present to the board and give an overview and answer any questions that you might have. Nels?
And I'm Nels Clouster. I'm an addiction psychiatrist. Been practicing about 19 years since residency. And I've been the medical director for VPIP for almost 2 years.
Great, thanks. And John?
John Valentine. Been on the committee for about 22 years and retired oncologist. And I serve as chairman, so I try to run the meetings. And I'm on the advisory committee where we discuss the clients.
Great, thank you. Now, and then Nels or Colleen, do one of you want to get us started?
Yeah, I'll take the lead, Jessa. Thank you. Yeah, and Rick and David, thanks you for inviting us back for a little information. We appreciate that. You know, PHP, we call ourselves a VPIP, Vermont Practitioner Health Program. So PHP is the acronym that we use. And there are PHPs in almost every state in the US. And the purpose of these is to ensure the safe practice of providers who might be struggling with mental illness, if not actual impairment. The way we call them participants when we're working together with them, and providers can be referred to us either through a board referral, which often comes either because of some event with bad patient outcome that is brought to the attention of the board, or during the license reapplication process. So, for example, if there have been, say, criminal charges for somebody related to mental health issue, substance use, then they're referred to us as well. And there's also the safe haven approach. You know, one of the important things that's been happening with one, as you know, probably better than I do, the application for licensure has changed. Vermont is one of many boards in the U.S. that has reframed their questions around mental health. so that is more focused on whether providers are able to practice safely at this time versus, actually being impaired from, say, alcohol use disorder or depression. Previously, simply the presence of any of these illnesses would have required a, say, positive answer on the licensing application, which we've realized over time has inhibited providers from seeking care that they might need. And we know that we as a profession struggle with mental health to the same or even a greater degree than the general public. So this has been a very positive step forward then to allow providers to seek help to continue to practice to their best abilities. And so the safe haven approach is when someone would contact us and say, I've been struggling, I need some help around my substance use or mood disorder. In which case, then we, either one of these routes, I do an assessment and determine is there a presence of a mental illness, and then based on that, could possibly refer them for more in-depth evaluation. The PHPs are not treating organizations. We monitor people's treatment plans, and that comes there are limited number of organizations across the U.S. that are specialized with a competence for evaluating potential impairments in a number of safety-sensitive professions. I think maybe airline pilots, truck drivers, physicians would be in this category. If I think that level of evaluation is necessary, then that usually can entail inpatient treatment, would entail 2, possibly 3 days of evaluation with various psychological instruments, PhD level providers, physicians who specialize in that area there. Also, we're part of the Federation of State PHPs. And this is, there's a national conference that's very educational, as well as a very collaborative organization. So I have any number of colleagues available to me for consultation and advice, and work closely with our neighbors in New Hampshire. We meet monthly to discuss cases and quandaries. So it's been very sort of helpful and supportive to make sure we're, doing the right thing here. We've also do a number of presentations throughout the state, to our chagrin, and not just in Vermont, but nationally. There are many providers or employers, organizations that aren't aware that PHPs exist. And in Vermont, our penetrance, that would be the number of participants you expect to have, is a little bit on the low side. So we have talked to med student groups, residency groups. We recently talked to bi-state group with FQHCs in order to make people aware that we are out there and available, and not as the joke goes, but we are here to help, and we appreciate this chance to advertise ourselves and our services to the board. And I think Colleen is that sort of a aerial view, and I'll let Colleen dive into some of the details.
So again, thank you for having us. So to begin, for someone, when they get referred to our program, either through the board or another channel, the process starts out by what we call an informational gathering time period, which is we request, medical histories, if they've recently got in trouble with the law, what that consists of, and the affidavits that they might have been served with, to get a better picture overall of what the issue is that's at hand. Once we get all of the requested documentation, Dr. Kloster performs an assessment to determine, based on the information that we've gathered, if it was an isolated incident or he's not quite sure if in fact there's an underlying issue. He makes a determination at that point, either to say, no, from all the information I've gathered, it's an isolated incident, and we'll notify the referring party, if there is one, of that's what the situation is. If it does, if he thinks that someone needs a more in-depth assessment, he will refer them. There's only one person in the state to do a general assessment, more in depth than Dr. Klosters. Otherwise, they get sent to one of a dozen throughout the country, and that consists of forensic testing as well as different questionnaires and counseling. And then they make a recommendation back to us on what they think should be done, be it contract monitoring or to do whatever they might recommend. So that's the kind of the nuts and bolts. I'm also responsible for the collection of quarterly reports for all of our participants. And over the years, it used to be paper, and now we've automated it online, so it goes much smoother and less of a having to round up all the documents and so forth. And then for any participants that are involved with the board, we send them a quarterly report indicating their compliance with their monitoring contract. We also do provide resources for people in the community or health professionals licensed by the Board of Medical Practice if they need, a therapist, not necessarily seeking out, an assessment, but just would like to see somebody and, wants to see somebody that has worked with the medical community. We provide resources for that. Again, Dr. Kloster has indicated that we are trying to get out more in front of groups to let them know that we are here. The VMS board is also well aware of our program, and they, if they work in a hospital, their hospitals are aware of our program. So we sort of do have somewhat, people that are out there that know our program and so forth and have been involved with cases where they need help at their hospitals and so forth. I sent to David the annual report. I hope you all had a chance to look at it. As Nels had indicated, we are, well, it's a good thing our program participants are graduating successfully, but we are not getting the referrals that are definitely out there. So we are looking at different ways to promote the program. And if any of you have any suggestions, that we would definitely like to hear from them. We do periodic articles in our weekly news or our rounds, so to speak. So people are aware of that for our membership. I usually give an update at the Vermont Medical Society's annual meeting of how the year in review goes. So that's, again, our board members are well aware of the program and it exists. I think I've touched on everything. As Dr. Kloster said, he attends the national meeting every year, which I have been to, and it is actually a really good meeting. And we do have our monthly committee meetings where we not only discuss the cases, but also administrative issues and policies that we set forth for going forward. Jessa, thoughts?
No, that's great, Colleen. Thanks. I don't know if you or John want to say anything more specific about the committee, sort of the role of the VIPIP committee, or what types of folks are on the committee.
Yeah, I can do that. And John, if you want to add to my comments as well. We have a variety of people on the committee. They range from, we have medical doctors, a couple of PAs. I don't think we have a DO. Some are new to the committee. Some have been on the committee for many, many, many years. We also have a licensed alcohol and drug counselor on our committee. And all of them are well, I don't know, versed or what have you, but some of them are in recovery themselves and others have been past participants, and it's been really nice to have a diverse committee group. As I stated, we do our monthly meetings every month on the third Thursday of the month. We just recently had an in-person meeting a couple weeks ago, and that was really nice to see everybody. And some of the committee members are actually what we call, they used to be called case managers, but that really wasn't an appropriate role. They're now referred to as peer advisors, and they just provide an additional support for a participant. And not every committee member has a participant, so to speak, but it's really important during the beginning of someone's monitoring, because as you probably are aware, you know, when you're being asked to be monitored, it's a very frightening and anxious time for these professionals. And I think it's a great resource to reassure them that, you know, everything can work, you know, providing you're compliant, everything will work out. You'll work it into your schedule and it'll become old hat. But I think it's a great resource for our participants. John, did you want to add anything to that?
Yeah, I want to just point out that the committee is a lively group, and you know, I have to say the final decisions, the big final decision is made by the director, by Nels. But I think the committee provides him with a forum and a variety of informed opinions on plans for therapy or what should be done with people, because it's very challenging for some doctors, for most doctors, to go from being independent practitioners to being monitored and watched and tested, and it can be a rocky road in the beginning. So the committee members try to facilitate that with the people that they're advising, and I like to think that we provide some help to Nels when he's coming to difficult decisions sometimes. But anyways, that's about it.
Yeah, no, I'll echo that, John. I feel very well supported by the vast years of experience on the peer advisory committee and Colleen's experience as well. For, you know, relative newbie, I've found it very comforting.
Pat, did you have a question?
Yeah, thank you for your presentation. You know, when I first became aware of VIPIP, which was back close to when it started, you kind of more were exclusively involved with substance use disorder. But now, as I understand, you're doing a lot more mental health in general. Is that correct?
Well, the statute changed, I think, God, 2017 to allow that the assessments on physicians' licenses be counted toward a recovery program and not necessarily just for substance abuse. So we have gotten referrals for behavioral or mental health issues. We don't do a lot of monitoring for them at this point. It's hard to monitor somebody that has a behavioral issue. We have done them, but we just don't get that many referred to us. Okay. So we are doing them, but we just don't get the referrals.
Where I really kind of wanted to go with this was something Nels mentioned, that you've talked to medical students, because I think medical students are a really important group for wellness in medicine. Obviously, I think there's a huge amount of anxiety in many medical students, not all, but many, and depression, and, you know, kind of all the things that go along with someone feeling comfortable and confident in their early career, and maybe and the transition to residency, which we know is very difficult. So that kind of sets people up for anxiety, depression, substance use disorder. So any ability for you to reach medical students and offer VIPIP as a safe haven, where there won't be anyone really at the medical school knowing the details of what they share with you. So I don't know how you've reached out to there's only one medical school, so that would be UVM. Yeah. I don't know what you've done, but there's just real opportunity, I think.
Oh, yeah. Yeah, and Pat, you're absolutely right. So kind of the first thing you sort of asked, you know, these PHPs were primarily geared towards impaired by substance use disorder physicians, you know, decades ago. And there's a recognition, of course, that needs to include all basically everything under the DSM, right, should be, and they're not just splitting up substances versus, say, depression or other mental health struggles. And even another area, as you'd mentioned, our wellness. At the last two national conferences, there's been a stronger element in the program regarding wellness and burnout.
Mhm.
So that is, that's another potential area that PHPs will be involved with. As far as med students, if you look at the mental wellness of undergraduates to medical students to residents and early attendings, you find there's an increased level of burnout, a decreased level of feeling well. That happens is, the training is sort of, it hurts us along the way as far as our well-being goes. Now, with the medical school, we had a meeting well over a year ago with Lee Rosen, who is the director for mental health services at the medical school. And I'm blanking on the name of the dean of students. But
Karen George.
Karen George, yes. And so we had a very good meeting with, I think, Jessica, Colleen, and myself, and those two people, and made a reconnection with VPIP and the medical school. COVID had led to a bit of a separation during that period, and we were very happy to renew that relationship, and they appeared to appreciate it as well. So we have had referrals from the medical school since then. So I think that was fruitful.
And coincidentally, Pat, we did just meet with the fourth year medical students last week. That was organized by one of our committee members. So she's involved with the school, so she's well aware of the program and so forth. And we did speak to them about burnout and mental health issues and about the resources that are available if, outside of substance use disorder. So, I mean, we did tackle on those subjects for those students.
I think they have like a wellness committee with student members. Would you ever consider having a student on your committee, or is that not appropriate?
I'm going to look to Jessa for that.
I actually think it would be fantastic. I think we'd welcome involvement on the committee, probably not in a peer advisor role, but in a sort of informing the committee. So yeah, that's a great suggestion, actually. So we could certainly reach out to our contacts there and ask if there might be a student interested. And I just want to piggyback a little bit on what Nels mentioned about the sort of the continuum of services between the most intensive kind of full monitoring contract with VIPPIP. Then there's kind of a consult with Nels or Colleen and getting community resources. And then the medical society, I mean, it's kind of a loose distinction, but the medical society separate from VIPPIP is also has sort of well-being programming. So we have a well-being collaborative, so a group of about 10 to 15 physicians who are meeting monthly with Doug Wasaki Johnson from Luminos, who I think has presented to the board in the past about well-being, to work on statewide well-being initiatives. Doug also does well-being presentations at medical staffs or practices. He's actually met with the medical students a couple of times, I think. And we're also working with Doug. A new program we're going to offer in 2025 is some no-cost coaching sessions with him. So again, the sort of the distinction of, maybe you don't quite need or want therapy or VIPPIP services yet, but you're really just thinking through your career choices, or are you happy in the job you're in? And so we try to kind of meet the professionals where they are kind of along that spectrum of services, and certainly happy to get other ideas and suggestions to make sure we're offering all we can.
Yep. Great.
Great. Dr. Kader.
Yes, I just want to say this truly is a wonderful program, and a number of excellent clinicians have been able to continue their career or get back to their career due to the efforts of the four of you and all of the other volunteers that are on your committee. So thank you very much.
Thanks, Dave.
The one question I know that we've had before for you, so it might be helpful just to speak to, is, I think we have a pretty good understanding when we have a case and we refer to you, sort of the process there, but the self-referrals, what is the safe sort of harbors there? And when is that case then referred to the board when there's a concern that it's affecting the practice of medicine? I think that comes up often, and I think it's important for the board to understand that.
I guess to start, Rick, is that with the Vermont Medical Society has a contract with the Department of Health for VPIP services. And in that contract, it states that any person involved with VPIP, there are, I think, 7 or 8 conditions that require a mandated report to the Board of Medical Practice. For instance, say harm to self, harm to patients, unprofessional conduct, breaking the law. I mean, those are all condensed items, but it's stated right in, and it's actually in participants' contracts as well as the Department of Health document. So I hope does that answer your question?
Yeah, and again, I think that's been a question from the board to VPIP in the past. And frankly, I also think that's probably a point that should be well communicated with the licensees, because really it's narrow, right? I mean, in the overwhelming majority of times when someone self-refers, their medical school is not going to know, their licensing board's not going to know, this is someone who's trying to get help. And then so long as you're not breaking the law or hurting patients, I think that's really important for people to know, because I do think there's a lot of fear and anxiety amongst licensees that if I tell someone the horrible things that's happening, it's going to ruin my life. And to the extent at which we can demystify that, I think it would go a long way to helping our practitioners here in Vermont.
I just want to add that the monitoring contract for the self-referrals is essentially the same as the monitoring requirement of the board referral. So they all get treated by us in a very similar manner.
And maybe since we're talking about the contract, I'll just add one area where I think VPIP and the board do and continue to need to work really closely together. We do have some participants who have and the contract is referred to as repeated non-compliance. So despite, Nell's meeting with them, Colleen meeting with them, often bringing them into the committee to have a meeting, some participants are, and Colleen can really speak to this more, follow every stipulation in their contract, no questions asked, sort of right with the program from day one. Then we have a few who, seem to, no matter all the meetings, all the encouragement, sort of missing tests, late tests, and that is and we tell them, and that's right in their contract. That's when we need to notify the board. And we have reached back out to the board, and it puts, all of us, I think it's really challenging of, what do we, sort of what other responses, what other recourse do we have? For VPIP, it's really either a referral to the board, or if it got to that point, telling somebody we actually can't continue to monitor you if you really don't want to be part of this program. So just, we have, we try to do twice a year, but at least annually, a sort of smaller liaison committee meeting with the board, kind of a work group to really work through some of these issues. And those are some of the more challenging of kind of what are the right responses? How do we work with the board on some of those cases?
Speaking of which, Jessa, David, I was hoping that we could schedule a liaison meeting. It might be a little challenging to do before the end of the year, but I'm bringing it up now to see if we can start the process for scheduling something.
We should, and I know that one of someone who's always been involved with that is Dr. Tortolani, and he's out hiking these days and not available. So I'm going to hold off a little bit. I'll send out an email asking for individuals who are interested. I think we've lost some of the regulars who would attend those, and now it's so much easier that we have teams. So it was nice when we met in person, but I'll send out an email and ask for people who might be interested and try and identify some dates, which is my least favorite thing to try and do, is find a date that works for all you busy people. But we'll work on that.
Thank you. Appreciate it.
Great. Any other questions for folks from VPIP? No? Well, guys, thank you so much for joining. We really appreciate your time and coming here and speaking with us, and look forward to having our next liaison meeting hopefully later this year.
Thank you very
Thanks so
much for
much.
having us.
Thank you.
Okay,
Thank you
thank
too.
you.
Thank you.
Take care.
Thank you, everybody.
Bye-bye.
Good-
Yeah,
good-
bye-bye.
All right. My hope was that perhaps we could vote to go into executive session and then take a break, because I at least need a bio break and to stretch my legs so I don't get a DVT. Are we all okay with that?
Yes.
right,
Motion
can
to
somebody
go
make-
into executive session.
Can I get a second?
Second, Tando.
Second, Tando. All those in favor?
Aye.
Aye. Any opposed? No. Great. So we'll see you at 2:30 on the other side. Okay?
Great.
So much.